have Jennifer Pate coming up. If you go ahead and switch. Dr. Pate is the Chief of Psychiatry at Baylor St. Luke's Medical Center here in Houston. She is the transplant psychiatrist for 5 transplant programs, and she sees patients with liver disease full-time. She also is a consultant for Intercept Pharmaceuticals. And please welcome Dr. Pate. You could just stay here. You just stay to the left if you could here.
Okay. All right. Perfect. All right. So first of all, thank you, PBCers, for inviting me once again. This is such a fun opportunity and a topic near and dear to my heart. Secondly, I'd just like to say that our thoughts and prayers are with those down the road in Santa Fe today. All right. So third, I want to commend all of you for giving up your seat at the royal wedding to join us here. And so I'm just going to finish getting ready here. Okay. Let's see. All righty. All right. So today what I'm going to talk about, first of all, I'm not going to trip over my bag. So today what I'm going to talk about is a topic very different than a lot of the other speakers. We are not going to be talking about Urso or Ocaliva. What I'm going to be talking about today is living with PBC. As many of you may know, I quote-unquote came out at the last PBCers meeting. I am also, despite being a liver doctor, I am a patient with PBC since 14 years ago. So I can honestly say I get it. All right, so let's move on here. All right, so just a few statistics. You know, we're kind of a little bit of a rare breed here, but what we're talking about today can also apply to a lot of different chronic illnesses. So 1 of every 2 Americans has a chronic illness. So most of you in this room have one, and if you don't, you likely know somebody else who does. We have about 19 to about 400 cases of PBC per 1 million people at last survey. So in addition to the physical challenges of PBC, the psychological issues also take their toll. And just to give you a heads up, my talk is pretty short, and that was intentional to allow plenty of time for questions. So if you think of anything, just jot it down. All right, so let's talk about some of the different psychological challenges of PBC. For one thing, it's very difficult to understand, especially, you know, even if you're a patient. It's hard to understand. It's hard to explain to people what exactly your liver disease is. A lot of times when you say you have a liver disease, people automatically think you drink too much. And, you know, when I reflect back on learning about my diagnosis, I was finishing up my residency after medical school, and I remember the first sentence out of my mouth was, "But I don't drink." And so even as a physician, you know, I was kind of following that line as well. Some of the biggest challenges are, for the most part, people with PBC don't look sick. You know, if you saw people with PBC walking down the street, you wouldn't think anything is wrong with them. So that's also a challenge. Your sense of who you are changes when you're diagnosed with a serious illness like PBC. There's a lot of unknowns out about the future. You know, am I going to do okay? Am I going to die from this? Am I going to need a transplant? So there are lots of questions that come up. The other thing, too, is once you have a diagnosis of an autoimmune disease like PBC, you will likely have other diagnoses of autoimmune diseases. Most commonly, problems like Sjogren's syndrome, problems with your thyroid. And so you kind of need to be on the lookout for other autoimmune diseases because PBC often does not exist in isolation. A recurrent theme I hear in my office when I'm seeing patients, which, by the way, I spend my entire day taking care of liver disease patients. So if you don't have a liver disease, I don't typically see that patient. But, you know, there's the chronic theme of disappointing others. And a lot of that's because of the fatigue. And I'm going to spend a little bit of time talking about that because that's probably right up there with itching, one of the most disabling symptoms. Something that is very, very, very important to remember is that symptoms such as itching and fatigue do not correspond with the severity of your liver disease. So you may have stage 1 disease and have disabling fatigue, terrible itching, whereas somebody with cirrhosis who's top of the transplant list may not have any of these problems. So don't think, oh, well, I have stage 1 disease, so I really can't have these bad symptoms. What's wrong with me? Again, the symptoms exist, separately from disease severity. All right, so let's talk about some of the different reactions to diagnosis. And I would say all of these are normal to some extent. So clearly shock. None of us go into a doctor's office thinking that we're going to be diagnosed with this, chronic liver disease. A lot of people don't believe it. Again, people think, well, I didn't drink alcohol. How can this be happening to me? People feel sad. They start thinking the worst. Oh my God, I'm going to need a transplant tomorrow. Well, that's pretty unlikely thanks to Urso and Ocaliva. Denial. But at the same time, there can be a lot of relief because you finally have an answer for what's going on. All right, so let's talk about fatigue. So it is clearly one of the most disabling symptoms. Even the liver doctors that I work with, not all of them, but a lot of them clearly don't understand fatigue. And people will often say, oh, take a nap. Maybe your work days are too long. Maybe you're not sleeping well. Maybe you need a sleep study. And so a lot of people will really misunderstand the fatigue. Again, like I said before, and I want to belabor this point, it does not correspond to disease severity. Fatigue is one problem that often does not improve with transplant, unfortunately. So people after transplant come to me and say, I thought I was supposed to be fixed. And a lot of times the fatigue isn't that much better, unfortunately. So fatigue and depression, which I'm also going to talk about today, are two different issues. And fatigue does not mean you are depressed, okay? And a lot of doctors don't make that differentiation, so keep that in mind. There are some symptomatic treatments available, and we're going to talk about those. All right, so there are a few different treatments for fatigue and PBC. One is an antidepressant called Wellbutrin. The generic name for it is bupropion. It is a very activating antidepressant. I would say it's a good choice for fatigue if you're also having depressive symptoms. People who should not take Wellbutrin are people with active eating disorders or a seizure disorder. Nuvigil or Provigil. Those are called wake-promoting agents. First responders use them, air traffic controllers, military use Provigil or Nuvigil to help with fatigue. The biggest downside of it is that it can keep people up at night, so you have to dose it very, very early in the morning. Stimulants, such as those used to treat ADHD, low-dose Ritalin, Concerta, Adderall, Vyvanse, those are probably our most powerful treatments for fatigue right there. People who should not take stimulants are people with structural cardiac disease, meaning you have something wrong with your heart. If you are a cardiac patient, you would want to have a stimulant cleared by your cardiologist. If you are on a beta blocker, such as propranolol, nadolol, for portal hypertension or esophageal varices, one of the things that you can do to help yourself with your fatigue is flip that to bedtime. I have a lot of people where I make that change alone, and people come back saying that they're feeling better. The beta blocker will really kind of suck the wind out of your sails. So flipping that to bedtime can make a big difference. All right, so let's talk about some real world pointers for fatigue. So step back and think about what is the best time of the day for you. For me, best time of the day is super early in the morning. My best brain power is probably about 4 a.m. to 9 a.m. If I need to write a paper, if I need to do something with a lot of thought, that's the time I need to do it. I'm not too productive later in the day or in the evening, and so I avoid scheduling a lot of stuff for that time. All right, so even though you're super tired, napping does not typically help. So what you have to worry about here is you want to make sure that your napping is not backfiring and keeping you up at night. If you're having a long afternoon nap, it's going to get in the way of you falling asleep at night. Make sure you are doing all the right things to help yourself sleep. So keep your room as cool as possible. Don't drink caffeine late in the day. If you're on a stimulating medicine, make sure you're taking it early in the morning. I'm going to talk about itching. Itching can really interfere with your sleep, and I'm going to talk to you about how to manage that. Avoid energy drinks. And I would say other supplements. Probably about 3 or 4 times a year at St. Luke's, we will have a young woman typically come in full-blown liver failure, not known to any of us, just comes in abrupt liver failure, and she was taking supplements to clean her liver, be more energetic, feel better, and she ends up dying before we can get her emergently transplanted. So my rule is, because supplements are not approved by the FDA, you're better off to not touch them. All right, so some low impact exercise, at least a couple of times a week, can help. And again, limit time in your bed due to quick deconditioning that will occur. All right, so let's talk about itching and liver disease. So again, remember, this does not correspond to disease severity. So itching impacts about 80% of patients with PBC throughout the course of their illness. One of the problems is it's much worse in warmer weather. So this time of year, I hear a lot of patients itching, getting much worse. It's also worse at night, and it can easily be triggered by a hot shower. So if you're having a lot of trouble with itching, flip your shower to the morning so that you're not setting off that cascade of itching late at night and then trying to go to sleep. Lots of my patients flock to dermatologists and are given different steroid creams, different topical things. Topical things don't work. There are a few lotions on the market that can be a little bit helpful. Lubriderm with the gold cap, Sarna, CeraVe. The efficacy of those is pretty limited in my experience, but if it gets you a little bit of relief, it's probably worth it. Antihistamines such as Benadryl, hydroxyzine, those are not helpful, and I would quite frankly just stay away from them, especially now because there's some cardiac warnings coming out about hydroxyzine. My gold standard of treatment for itching, the thing that I go to first, is cholesterol or cholestyramine. These work by binding the bile acids out in your bloodstream that are causing the itching. So the downside is you have to space them out away from your other medicines, because just as they bind bile acids, they'll bind your other meds. So you have to be really careful and work with your pharmacist or your physician on how to best take those. Cholesterol is a big horse pill that most of my patients prefer over cholestyramine, which is a really gritty, sandy, orange-flavored liquid that's really disgusting. And so a lot of people prefer the horse pill of cholesterol instead. Now, there are some studies that say that a 10,000 lux light box can be effective. So if you look at these on Amazon, they're probably about the size of an iPad screen. And what you can do is, when you're reading the paper, just sit in front of it. You don't have to be naked. You don't have to be looking at it. Just have the light box right in front of you. And these have really come down in price. And I think you can probably get one for about $30 or $40 on Amazon. So there is some literature about bright light therapy being helpful. The other thing, too, is if you're in a part of the country where you have lots of very dark days, like where our friends are, from Intercept, if you're having some seasonal issues with your mood, when the days are shorter, it's getting dark very early, the bright light box can help with that, too. All right, so one of the things that everybody with this needs to figure out is, are you sick? Are you tired? Are you depressed? Are you anxious? Or are you all of the above? So let's walk through some of these. All right, so let's talk about depression. So depression is one of the most common complications of all chronic illnesses. Depression is not a weakness. Depression is a neuropsychiatric medical condition. So it's not that you're a wimp or you don't have any willpower, it's that you have yet another disease. So up to 1/3 of patients with serious medical illnesses experience symptoms of depression. As I'm going to talk about, depression is not normal. Okay, so I have physicians who will call me to see a patient and they'll be like, oh, they've got this problem and they're critically ill, so they're depressed. And I say, just because somebody's critically ill doesn't mean that they're depressed. A lot of critically ill patients are not. So it can often take somebody like me to sort this out. Depression is highly treatable. And one of the really interesting studies that came out a few years ago showed that when we treat depression for people on a liver transplant list, the treatment of depression actually improves your chances of survival. So if depression's an issue for you, it's really important that we get on top of that problem as well. So let's talk about what depression looks like. Now, the complicated thing is, as we move through these symptoms, you're going to think, yeah, but my liver disease does this too. So it can be sort of difficult to separate. So depressed mood, feeling sad or down, losing interest in activities. Maybe you used to like, drawing or painting or getting together with this group of friends, and you kind of don't have any interest in that anymore. Significant weight gain or weight loss. Okay, well, that can go with liver disease. Sleep disturbance. Problems with being restless or being slowed down, fatigue or loss of energy, again, a hallmark of PPC. Feelings of worthlessness or guilt, I'm a burden to my family. I feel sorry that my husband has to deal with this. Maybe my family would be better off if I wasn't here. Difficulty with concentration. The problem is there's something called PPC fog. There's also hepatic encephalopathy. Both of those issues can interfere with concentration and attention. So again, it can be sort of difficult to set out. Thoughts about death, especially suicidal thoughts. If you're thinking about ending your life, especially if you have an intent to do that and a plan to do that, that's a real live psychiatric emergency. You need to call 911 or go to an ER. All right, so let's talk about some of the symptoms of depression and chronic illness. Pain can be involved, especially if you have autoimmune arthritis or problems like that. If chronic illness disrupts your routine, puts stress on your relationships, you can have some conflicts with your medical team, which I'm going to talk about a little bit because that's one of my favorite topics. You lose control. There's a lot of uncertainty about the future, financial stress, which there are luckily a lot of resources out there to help us afford our medications. Fatigue, medication side effects. All right, so the problem is, again, a lot of doctors say, oh, well, of course they're depressed. So we've got to help doctors get out of that rut. The other thing, too, and I hear this all the time, especially being in a tertiary care transplant center, the liver doctors, by and large, focus on the liver. They talk about your labs, they talk about your imaging, but they don't talk about how are you dealing with coping with this illness. And so you guys are often left to kind of, manage this on your own. All right, patients are afraid of looking needy or, quote unquote, looking crazy. If you're depressed or anxious, that doesn't make you crazy. Patients are afraid that once they have an identified psychiatrist or are on psychiatric medicines, their medical issues will be dismissed. There are also some fears about the extent of psychiatric treatment. In this country, we're moving closer to mental health parity, meaning coverage for psychiatric treatment will hopefully at some point be right on par with coverage of medical treatment. However, in almost every city, there are some resources for free psychiatric help, and I'm going to talk to you about how you guys can access that. All right, so the problem with depression and PBC is There are also often medical conditions that also cause depression. Hypothyroidism is, in my practice, almost universal in my PBC patients. If you are, meaning your thyroid is low, if your thyroid is low, then that needs to be treated because that will improve your cognition and it will improve your mood, improve your weight control, your energy. So that's not a problem that we want to miss. Asthma, Cushing's disease, diabetes, other autoimmune diseases such as rheumatoid arthritis, lupus, neurological issues, nutritional deficiencies, and cardiac disease are all known to cause depression. Let's look at some of the medications that can actually cause depression. So some antibiotics, steroids such as prednisone, can cause all kinds of psychiatric symptoms, including depression, anxiety, insomnia, medicines for diabetes. Luckily, we aren't using much interferon in the realm of liver disease anymore, but back a few years ago, it was one of the mainstays for hepatitis C and caused horrible psychiatric side effects. Antivirals that are used to treat herpes virus infections, such as shingles, can cause depression. Some of the cardiac drugs, birth control pills, anticonvulsants such as Keppra, anxiety medicines such as Xanax, Klonopin, Valium, those can all cause depression, as well as opiates. All right, so how do you know if you need professional help for depression? I would say one of the biggest ways you can figure this out is how much is depression getting in the way of my functioning? Are you missing work because of it? Are you not getting to your volunteer activities that you did before? Are you not engaging with your family on a level like you did before? Those would be some of the warning signs I'd look for. If you're having a lot of trouble sleeping, a lot of times a problem with depression or anxiety can underlie the sleep disturbance. One of the biggest concerns, especially in a chronic disease like PBC, and especially after liver transplant, if your depression is interfering with your compliance with your medicines, that's an emergency. Have you hit a rut where you're like, oh, I'm just not going to take all these medicines anymore? I don't even think they help me. What's the point? Okay, that's a sign you need to get some help for your depression. You attempt to self-medicate through using street drugs, marijuana, alcohol. That's a real problem, and you need to get some help. And again, if you have suicidal thoughts, that's an emergency. All right, so let's talk a little bit about treatments for depression. We won't go into this in too great a depth, but I want to kind of outline some things. So psychotherapy or talk therapy, and then medications are how we treat depression. So some of the psychological treatments for depression can include reading books. One of my favorite workbooks for depression is called Mind Over Mood. If you order this book, get it in paper, not electronically on a Kindle or iPad, because this is a workbook like we all used in school where you sit and write in the book. And so that's kind of impossible with an electronic form of it. And this is also not a book that you'll just plow through, like, curl up in bed one night and just make your way through it. This is a book that you really have to work with and use the tools that it teaches. Journaling, support groups, writing, volunteering, exercise, pets, surfing the net in moderation. If you are spending all day reading all of the scientific literature on PBC, and you're trying to figure out how you would do your own liver transplant, you need to back away from the internet. There are literally patients who say, oh yeah, I'll say, how much time are you spending on the internet? Maybe 8 or 9 hours a day. I said, okay, you get 1 hour in the morning, you get 1 hour in the afternoon, get a kitchen timer or set the timer on your phone, have at it. When the alarm goes off, you're done. And it helps. By the way, I also use that strategy for patients that are agitated by the media. Media coverage of various topics that I won't lay out. But I literally have to tell patients, all right, pick your one news show a day. That's what you get. After that, TV's off. Hey, it really works. All right, so let's talk about medication management of depression. We're doing just fine on time. We're going to have plenty of time for questions. All right, so not every antidepressant is safe in the context of liver disease. So you really want to make sure that all of your treaters understand that you have a liver disease and know what medications are safe in that context. You also want to make sure that either you or your physicians check your medication interactions. There are plenty of medication interaction checkers on the internet. You simply type in the meds and it'll tell you how serious the interaction is. Identify the target symptoms. Are difficulty sleeping your biggest problem? Are difficulties with appetite, your energy? Identify those target symptoms that are most problematic, because those will help your doctor pick out a depression treatment for you. You know, we use some of the side effects to our benefit. So let's say somebody has very poor appetite and sleep problems. We may go with a medication like Remeron. The other name for it's mirtazapine, because the side effects of those medications actually treat those target symptoms. All right, so if you have cirrhosis and if you have hepatic encephalopathy, which is a whole nother topic, but basically rapid variation in ability to pay attention. You may have some changes in your handwriting, difficulty maintaining alertness during the day, problems like that. You want to make sure the hepatic encephalopathy is treated, and the two treatments for that include lactulose or crystallose and Xifaxan. So if you're having hepatic encephalopathy, it may not actually be depression that you're experiencing. It may be hepatic encephalopathy. All right, so let's talk about other medications for depression. In the context of PBC, my favorites are typically not antidepressants, ironically enough. My favorites include stimulants, like we talked about, Ritalin, Vyvanse, Concerta, Adderall, or Nuvigil or Provigil. The great thing about stimulants or Nuvigil or Provigil is they typically work first dose. So you're not looking at a ramp-up period like you would with a traditional antidepressant. Literally, you can take it and get some benefit right away. All right. So I really think part of living successfully with a chronic illness is maintaining a sense of purpose. You know, you just can't crawl up in a hole and, you know, turn out the lights and hide from life. I think one of the important things that's been especially important for me, and the reason why I do this work I love so much every day, is because having a purpose is so incredibly important. So continue to work to the extent possible. If you're with a big supportive company, see how they'll work with you. See if you can modify your schedule. You know, if you're a morning person, schedule the bulk of your work earlier in the day. Look at different modifications that can be made. If work is something that's impossible for you, consider volunteering. You know, the great thing about volunteering is nobody's going to fire you. You know, if you show up, great. And if you don't, then it's not a big disaster because your presence is literally a gift to them. Stay involved and get out of the house every day, even if it's, you know, driving around the block, going to the dog park, you know, running to the pharmacy, you know, visiting briefly with friends. Try to stay active and get out of the house. All right, so let's talk about anxiety. So what exactly is this? You know, I think it's kind of interesting because I'll ask patients, I'll say, well, do you feel anxious? And people will be really confused and say, well, what's that mean? So that means, are you feeling very stressed, uptight? Are you irritable, cranky? Is your family saying, wow, you're really snappy and impatient? You know, that's a sign of anxiety. Are you preoccupied with worry? You know, do you have these thoughts, you know, constantly going over and over in your head? Are you ruminating? Do you feel nervous or jittery? Are you having panic attacks? You know, those can just come out of the blue without a trigger, and all of a sudden you feel like you're dying. Chest pain, shortness of breath, sweating, not like my sweating that's a hot flush right now, but, you know, this feeling of, oh my God, I'm going to die. And typically panic attacks only last a short time, but they can be really, really scary for patients. And that's a sign of an anxiety disorder that should be treated. All right, so let's look at some of the medical causes of anxiety. Again, if you have cirrhosis and you're having some trouble with hepatic encephalopathy, that in and of itself can be manifest as some anxiety symptoms. Other medical causes include thyroid problems, especially if you are a hypothyroid and your thyroid disease is being overly aggressively treated. That can cause anxiety. Heart disease, asthma. Oops, I have heart disease twice. Sorry about that. Substance abuse or withdrawal, and then different medications. Immunosuppressants such as Prograf, Celsep, prednisone, all of those can easily cause anxiety, and I see that every day. All right, so knowledge is power. You need to learn about your illness and be your own best advocate. Everybody in this room who has PBC ought to know their alphos at every moment. The problem is physicians are busier and busier, and the demands on us are just growing exponentially. It is very easy for a member of your medical team to miss something. So you need to be your own best advocate, track things, and when you see something deviating from your version of the norm, you need to point it out to your doctors. So we're going to talk a little bit about how to communicate more effectively with your healthcare team. And also, one of the benefits of knowing about your disease is it empowers you and gives you more of a sense of control. All right, a little bit about medication treatment of anxiety. The typical antidepressants such as Lexapro, Trintellix, Zoloft, those can help with anxiety. Benzodiazepines, I almost never use Xanax. Xanax is one of the worst drugs on the planet, probably second to heroin. Benzodiazepines like Klonopin or lorazepam can be used with caution in earlier stages of disease, but you really need an expert managing that. Buspar can help, as can beta blockers that we use for portal hypertension like Nadolol and propranolol can also help. Whoops. Okay. A few behavioral strategies to manage anxiety. Limit your caffeine. Also, exercise can help. Improving your sleep can help. Relaxation and mindfulness can help. If you're somebody who has panic attacks, make a list of strategies that help you so that when you have a panic attack, you can pull out your index card and you'll have your toolbox there and know how to manage your panic attacks. That really works. Like I said, limit your news watching. If you're a real worrier, maintain a worry list, especially if worrying is keeping you up at night. A lot of people, part of what keeps people up is you think, oh my gosh, I gotta remember to do that tomorrow. Well, just write it down. That way you can let it go. All right, set aside time to worry, and anxieties.com is a wonderful resource. All right, so let's talk about one of my favorite topics, which is conflicts with your medical team. Patients are from Pluto, doctors are from down under. I have patients every single day who say, you know what, it's not the disease that's getting me down, it's Dr. So-and-so. All right, so let's talk about how you manage your medical team. All right, so hopefully your doctor is doing the very best they can to do their part, but you have to do yours as well, okay? Bring a prepared medication list, okay? Telling us that you take a couple of these little round white ones does not help anybody, and there are probably millions of little round white ones, and we have no idea what that is. So you have to know your meds, your doses, who's giving them to you, and what it's for. Because otherwise we can't really help you so much. Make a brief summary of your current symptoms or your current problems that you're having. If you've seen a lot of doctors since you last saw the doctor that you're seeing now, prepare a little summary. So you can say, okay, I saw my immunologist and this happened, saw my cardiologist, this happened. And so we'll kind of know what's going on, especially if the the healthcare systems aren't linked. Make sure when you're having an issue, you take it to the correct doctor. Okay, so going to your dermatologist and discussing your fatigue is probably not going to be very high yield. Now, I did an experiment. So I had a bunch of patients in the hospital at one time, and they were very frustrated with, excuse me, a particular doctor, and they said, this doctor comes and bolts out of the room so fast we can't get any questions asked. So I went around one afternoon and I said, okay, look, we're all going to try an experiment. So I went around to the various rooms of the patients I was seeing, and I passed out index cards. I said, write your top 2 or 3 questions for Dr. So-and-so, okay? As soon as he takes a breath at the end of his visit, you jump in and say, Dr. So-and-so, I have 3 questions. Number 1 is this. And then I went back around, saw all my patients again, and I said, so how'd it go? And they were like, oh my God. He slowed down and listened to me. So it's going to take a pretty rude doctor if you say, I've got 3 questions, and you start rattling them off. If he walks out of the room while you're midstreaming questions, I would say you might want to shop around for a different doctor. But that works very well. So from the side of the physician, if you say, I have 3 questions, that's actually a little reassuring to us because we know we aren't going to be held hostage there all night. Okay? 3 brief questions and everybody's happy. So think about that. Identify your goals for the appointment. Get any refills. If you're needing letters for something, get that too. All right, so here I have a few books on chronic illness. I assume you guys will be getting a copy of my talk, so I'm not going to go through these. These are just some of the ones I really like. Again, another list. All right, so here are some different ways that you can find psychiatric help. Probably one of your most effective ones, if you have medical insurance that is something other than Medicare or Medicaid, is to look on the back of your insurance card, call the number, and you can say, I need to find psychiatrists accepting new patients. And typically they'll have a list of people. You're certainly always welcome to call my office, tell me where you are, and I'll do my best to hook you up with somebody, or you're all welcome to come see me. I'm fine with that too. If you need low-cost psychiatric help, there are lots of resources in your community, so you can look at low-cost or free psychiatric care in your zip code or in your town. So here are the other princesses for today. And John Bierling, this is for you. All right, so questions? Oh, okay, good. We have, okay. Okay, so this question, excellent question. What about low-dose naltrexone for itching or fatigue? Okay, so my basic algorithm for itching is I always start with cholesterol, which is a horse pill, or cholestyramine, which is a sandy, gritty, orange-flavored drink. That's my first step. After that, I'll do things like sertraline, which is Zoloft, an antidepressant. I'll use ondansetron or Zofran. Sometimes I'll use some gabapentin. My problem, and naltrexone is not particularly helpful for fatigue, so I don't even get there with that. For itching, it's okay. The biggest problem with naltrexone is it does have liver toxicity. So you either want your liver doctor to be writing this, or if somebody else is writing it, that they're doing it in collaboration. So Dr. Bierling and I have a patient post-transplant who we eventually had to use naltrexone for the itching. It worked perfectly, but we walked hand in hand with this and really watched his labs. So you have to watch for some liver toxicity, and it would probably be my 4th or 5th step. So this is not my go-to thing. All right, so We don't clearly understand what PVC fog is, but we know that it's a real deal. It can be very hard to separate, and one of the good things is we really don't need to because, in terms of stimulants, that can help HE to some degree. So you have to be cirrhotic to have difficulty with hepatic encephalopathy. So if you have stage 1 or stage 2 disease, it will not be hepatic encephalopathy that you're having a problem with. But the two can be very difficult to sort out later in the game. The good news is the treatments for hepatic encephalopathy, including lactulose or crystallose and Xifaxan, the good news is there's essentially very minimal risk, so it doesn't hurt to try those treatments. But yeah, the two can be very difficult to separate out. The only time it's particularly easy if it's early in the disease. Yeah, I'm assuming somebody that's more tech savvy than me can take care of this. I'll leave that to you guys. Okay. All right, so I think a little bit of exercise is a good thing. I go home from work and I walk with my girls. The big problem is if you're staying in bed or you're laying around a lot, you're going to become very deconditioned, which is going to impact your overall health. So what I would look at is, first of all, what do you enjoy? What do you have time for? And I would say do a little bit of something. And based on your other medical issues, you may want to talk to your doctor about what can be the best types of exercise. We're about to be in the scorching heat of the Texas summer, and I would say go to your neighborhood mall and just walk inside where it's air conditioned. Even something small like walking can make a big difference. It's healthy for your mind, it's good for your bones, good for your heart. So do whatever you can to stay active.
This was about a correlation between CBC and the changes of the facial area and the frontal lobe. Shrinkage of that. If you want to address it, Dr. Wheeling?
I'll talk about that.
Okay. We'll save that for Dr. Wheeling. And Xanax, you mentioned not a good choice, recommended alternative.
Okay, so let's talk a little bit about the family of drugs called benzodiazepines. We've still got 10 minutes, so we're okay. All right. For older patients, there is a list of medicines on a list called the Beers list. BEERS. It's essentially a list of high-risk medications for older patients. So Xanax is right there. The problem with benzodiazepines is, one, they are addictive. Two, you will over time become dependent. And if you land in the hospital for something and a medicine in the family of benzodiazepines is abruptly stopped, you can die. You can have seizures. You can have a syndrome that looks very much like alcohol withdrawal. This can be life-threatening and kill you. So if you're on a benzodiazepine, make sure anytime you have even a trivial surgery, you make sure to tell your surgeon and your anesthesia team, I am on fill in the blank long term. So this includes Xanax, Valium, Klonopin, Ativan, among others. The specific problem with Xanax is it is very short-acting. So what that means is you're anxious, you take a dose, you immediately get relief, and then you become a slave to this drug, and you're looking at your watch thinking, okay, when can I have more Xanax? When can I have more Xanax? It doesn't mean you're a drug addict, that you're having this problem. It's you're on a medicine that is a bad choice. So in very select cases, I'll use low-dose lorazepam, low-dose Klonopin, but these are especially problematic in patients on opiates and in patients with cirrhosis. The other thing, too, is if you're having regular endoscopies or colonoscopies, you need to make sure your liver doctor is aware that you're on a benzodiazepine. because you will be more difficult to sedate. So if they use a medicine like Versed to help you kind of nod off so that they can do the scope, you will require more of that medicine because you're used to being on that family of medicines. So I literally have one patient in my practice on Xanax, and that is because he uses it twice a year to get on an aircraft. Other than that, I don't prescribe it. It's a horrible, horrible drug. If you're on Xanax, talk to your doc about a safer choice. Oh, thank you. Wow.
This one is kind of personal. Basically, I think everybody appreciates you sharing that you have PBC as well. How do you distinguish those boundaries with the patients and with colleagues?
All right, so we have about 6 minutes left. All right, so I really wasn't planning to, as you say, come out about having PBC at the last PBCers. I had a wonderful lady that was newly diagnosed, and I won't identify her, I'll let her identify herself, but she had been diagnosed within the last 48 or 72 hours. And she came up to me after my talk and was understandably freaking out. And she's like, I just got this diagnosis. I saw this meeting was happening here. I just got on the plane and came. I have no idea what's going on. I need help. And so I pulled her aside and I said, okay, look, I get it and I have it. And so I was with some of my Intercept friends at lunch, and I don't know what occurred to me, but I just decided I'd throw them a bone and be like, oh, and hey, by the way, I have PBC. And of course, everybody was just completely dumbfounded. And so I really didn't expect to come out. I don't advertise this with my patients. I have recently gone public about this and done a satellite media tour in collaboration with Intercept to raise awareness about PBC. At last count, it's reached about 14 million people, probably a lot more by now. But I think, so I had been reluctant to share that openly because I didn't want my liver teams to question whether or not I was impaired. I can honestly say if I had the least doubt I was impaired, I would stop practicing as a physician. And so I got over that hurdle and I thought, you know what? I think this unique perspective as both a patient and a physician could help people. So I let people find out about it on their own, except for my patients with PBC. I have privately told them, hey, look, I have this too, so that they would not hop on the internet and find out about this for the first time after they've been seeing me for years and years. So the vast majority of my patients don't know, they know I have a congenital immune deficiency because I have to modify my practice a little bit in terms of infection exposures and things like that. And by the way, that story's on, you can Google Jennifer Pate and Fox News. They did a story about my immune deficiency, but I am not open about this in my practice unless somebody asks. If somebody says, hey, why do you get this so well? Or, you know, why do you choose liver patients? I'll tell them, but I don't broadcast that. So I hope that helps to answer the question. All right. Thank you, everybody. Great questions.
Yeah, thank you for
Absolutely, and I'm happy to leave the basal ganglia one for John.
Okay.